is United Medical ACO weekly event, and my name is Kemal Erkan. I'm the chairman of United Medical ACO.
Hello, everyone. Thanks for having me, Kemal. I'm Anthony Onugu, the Director of Contracting. Been with United Medical for about 5 years, focused largely on the management of contracts, specifically the value-based contracts and the overall transition from fee-for-service reimbursement systems to more value-based and value-added care, and helping with transitioning our providers to a new approach, to an enhanced approach to the care of our patients, and looking at them not simply as individuals, but from a more holistic and population-based approach. So I'm happy to be here.
Thank you, Anthony. And I know you're actually always there because while I'm doing other live sessions, you are sending me messages, and sometimes you are sending me corrections, and sometimes you are sending me your disagreements. So I'm going to bring one of the slides from last week when we had the issue of hospitals' positions on the mandate. This is from Delaware hospitals. I put them in two different categories. One, they actually, before the state mandated, they started with their own internal mandates. So Christiana Care Nurse and St. Francis, and on the other side, Bayhealth, Nanticoke, and BB did not mandate it. However, while this was happening, we have our state regulation hit the news, and this is from your PowerPoint.
Yes,
and this actually already covers acute and outpatient providers.
Yes,
and pretty much it makes the first slide kind of moot in a way that it's not relevant anymore because this overrides that first one.
Yes, because all of these facilities are regulated by the Division of Healthcare Quality, and the mandate covers all of those entities. So irrespective of perhaps the lack of a public announcement before this mandate by Bayhealth and by Nanticoke, they are directly covered by this requirement, and are expected to implement this by the start date of September 30th. I think.
You see, I think the communication is one of the biggest problems, and how we are communicating with public. So if the state was going to override all the decisions that these healthcare facilities were going to make, the first, when they came out with their own way of their own policies, the issue is they give this message of some are okay to mandate and some are not okay to mandate. You see where I'm going?
Yes, yes.
So this misconception, misleading of mandate is not necessarily supported or not necessary by certain hospital groups versus the other group. And then a week later, the state comes out and then says, well, everyone is going to be following this. So the confusion is already built in. So now we are trying to get out of that. So it could have been easily eliminated if state just comes out and then just makes this from the beginning, rather than just asking hospitals to make their own mandates, if this was going to happen anyway.
Yes, but part of it is, as you know, the intersection of politics in this, and it appeared that a number of the states and, of course, the federal government, as we've seen, seem to default to leaving this perhaps difficult decision to private employers initially, and then subsequently, especially as the Delta variant grew in the rapidity of its spread, now decided to invoke the legal authority that they have in certain cases to now impose a mandate. For instance, we see that with the announcement by the Biden administration and subsequently by CMS requiring all nursing home and long-term care facilities that do receive Medicare payments, requiring them to have their staff vaccinated as a condition for continued reimbursement through CMS.
So now, although one difference that I have maybe is the state employees and the state decision and the private employers that you mentioned. In this case, hospitals, although they are private, they are not necessarily fully private when it comes to the decisions like this, because they are part of the state committees. You and I, we are kind of like, we make this one of our issues in terms of our communication with the state from the policy-making, decision-making. So the hospitals are very much in the decision-making process with the state. So they could easily actually make this more like a proper decision, so that it would be one whole decision rather than a private employer of the hospitals and the state employees or state decision. So the point that Anthony, I'm trying to make on this one is it's the how we are delivering that message and timing of that message. So the overall communication, and there are already people who are confused, and then they already make different conclusion from everything that we say and when we say it. So it kind of gives them more arguments when there are differences, especially at the hospital levels.
Yes, in addition to the fact that it creates a discordant situation where some hospitals have the mandate and some others don't have it. The state always had the legal authority to set mandates. They always had that. It's the federal government that doesn't have that. The authority has always lied with the state. It goes back to the 1905 Supreme Court judgment in Jacobson versus state of, I believe, Massachusetts, which has set the legal standard for public health authority in vaccine matters with the states and the local counties. So that's always been well established, and the state had the authority to set this mandate and therefore have a uniform standard across the state, rather than the point you made earlier of the patchwork approach where you had Christiana, you had Nemours with vaccine mandates, and then so the other hospitals effectively waiting for the state to require them before now setting these up. You will wonder to yourself, for instance, the Christiana employees have been implementing this over the last several weeks, whereas some of the other hospitals now have to wait until September 30th. They're all hospital employees. They're all patient facing in terms of most of the employees anyway. So why that difference in standard?